Hello, my name is Jimmy Lin. I'm the Chief Scientific Officer at Pheno. And this will be the second talk I'm giving here at the conference. Again, thank you for the conference organizers for the invitation. I'm able to present some of our work. The talk today is titled Measuring Molecular Residual Disease using a Tissue Agnostic High Sensitivity Platform. My earlier talk, we talked about early detection of lung cancer. And the context here is thinking about MRD in this context there. Right now, we don't have any lung-specific MRD data we'll be showing, but organizers have asked us to show some of the data that we have in colorectal cancer there and provide some of the background. So hopefully this will be helpful to those in the audience here. Just a sort of quick recap in case people sort of didn't see my other talk there. Freenome is an early cancer diagnostic company based in the San Francisco Bay Area. I apologize, can't be there in person there. We are working on different personalized cancer detection tests to be able to catch cancers early. In the other talk, I talked about our efforts in working on lung cancer. We're starting with CRC screening first, but then to add lung cancer on top of it there. So we've been working on that, and we'll be launching LDT this year in lung cancer there. We also start building everything off of a colorectal backbone that we started first, and this is a study that we published last year in JAMA with over close to 50,000 patients, of which 20,000 of them were analyzed to build a best-in-class colon cancer test there. This is going to be important because our MRD test be able to look at so little amount of tumor signal in early detection setting is very similar that we leverage be able to look for minimal residual disease there. And colon is our first because we can leverage colon cancer in terms of a large intended use population, everybody over 45 years old in the US, and then lung cancer. But then this can be used for multiple different cancer types. And then is the fundamental technology that also powers our MRD efforts as well. We start off our technologies with a multiomics technology, looking at DNA, protein, RNA, and the technology that specifically we'll be sort of looking at there, and I previewed a little bit in the other talk, is looking at methylation technology there. When the samples comes in, we'll be able to look at the DNA as well as protein. And specifically today, we'll talk about on the DNA side, specifically looking at methylation and our methylation that enables conversion is base level information there. And our CRC test, which also being used for MRD, has already signals. We have put in panels for 10 other cancer types. So the same platform and the same technology can be used for MRD, for CRC, as well as for lung, as well as for other cancers there. And I showed here in earlier talk, looking at early detection in terms of our performance here, being able to get to 80% sensitivity at 75% specificity there in lung cancer there. So how do we think about molecular residual disease there? My background is actually I was the Chief Scientific Officer on Natera and helped develop the Signatera test, which is in the middle. It's a tumor-informed test. You sequence the tissue up front there, and then you design assays downstream that's personalized and be able to look for those variants. Very proud of those efforts. Natera sort of knocked it out of the park. Very, very proud of that test. It has detection in terms of 10 to 50 parts per mil there. But there's new technologies coming out, and there are new ultra-sensitive technologies, for example, like Foresight and Personalis, that's not only looking at mutation, but looking at sort of phase variants and other methods that's getting lower than 10 parts per million here, 0 to 1 there. And you can see that, Natera acquired Foresight, and there's a lot of partnership to be able to do that. But these technologies require the tissue to be sequenced up front. How about if you don't have the tissue? Tumor naive, right? Or you have biopsy, so little. So we've developed a method that is tumor naive, based off of just methylation, but it's just as low in terms of the performance as the sort of the earlier version there in terms of the tumor-informed methods there. But again, you don't need to personalize it for every patient. You have, and it's universal there, and it has very fast turnaround time there again because you don't have to sequence a tumor there. So this is the technology that I was talking about in terms of our approach in terms of a tissue naive or tumor agnostic method there. We think that this is very, very important, in settings where, for example, after surgery, right? If you want to sort of look in those, there's sort of residual disease there. Of course, the ultra sensitive is the best, but again, many of these settings you don't have tissue, or you need sort of fast turnaround time, especially if you want to make clinical decision making after surgery in the adjuvant setting there. Again, the fast and universal method is going to be important, and also for monitoring too. Again, if you think that potentially the tumor signature has sort of changed there, so. We think that the method is there helpful. On the lung cancer data, I'm not going to talk about this in particular, but we presented this small cell lung cancer data that we worked with Genentech and Empower at ESMO last year. And if you're interested in some of the work that we've done in small cell lung cancer, here you can sort of take a look. But today, again, on the MRD side, also specifically talking about our work in colorectal cancer there. But overall, the LOD in terms of the limit of detection there that we've done, and this is the work that we built off of our CRC test, is down to the 2.6 times 10 to the 2.6 times 10 to the negative 5 there. So that's, again, in the sort of 27 parts per mil range again. So we're able to sort of detect, again, without tissue upfront and down to very, very sensitive amounts there. Here's a study that we did here, starting applying this technology in the MRD setting for CRC cohort there. You can see that these are patients undergoing adjuvant treatment there, and this is where you can see it within the blocks there. For the patients that are here in the orange who have complete remission, here you can see here, by the end of their adjuvant treatment, they've all been cleared there. Right? If it's an open circle, there's some noise in the beginning, and all these patients basically are ultimately clear. So this is 100% specificity there. In terms of the patients that progress on the purple here, you can see here at least sort of this is in weeks within sort of 2 years. You can see here again, they all have sort of residual disease at the end, even at the end of their treatment here. There, so in about 2 years. But then if you go further out, because we don't have intermediate time points, these are a little bit harder to interpret. But again, for the patients who we have the data within 2 points, again, we catch all of them there. We don't do as well as the ones sort of in an intermediate, but if you look there, but you can sort of see here. But overall, if you add them all together, we have a 78% sensitivity at 100% specificity, sort of in this is pilot cohort there. How does this compare? It's very hard to compare across cohorts, but the Kaplan-Meier curve is helpful, right? The one, again, you see many of these types in MRD setting. Again, if you don't detect anything, these patients will do very well. If you detect some, they don't do so well there. You can see here the amount of the score are sort of very different there. How does it compare with the other studies? Again, very hard to compare across studies here. And we, different ways of sort of measuring. If you want just 2 years follow-up, all patients, pre-surgical, so these are the census spec. We show all the different types of numbers here, but you can compare to other tumor agnostic methods there, specific from Garden. And these are some of the numbers you can look. Again, not all studies are easily sort of compared, but we just sort of show you that sort of in context there, and then also sort of Tempest and Grail. But if you can look at Natera's, early Signatera studies there, again, these numbers are sort of in that range. So this is very, very promising. We think we're excited that without tissue being sequenced up front, we can get to such low amounts to be able to look at minimal residual disease in this sort of CRC setting. So hopefully this gives you a sense there. Although we don't have specific sort of lung cancer data, we are working with some partners with that. I mean, if you have a data set, some samples you're interested in working on, feel free to sort of contact us. We think that this is a pretty amazing opportunity to be able to take things that we do in early cancer detection to put in the MRD context there. We will be presenting our MRD data there at ASCO of this year. If you're ever at that conference of May of this year, come talk to us. We'll be sort of presenting sort of additional data for MRD. Hopefully this sort of 10-minute quick talk is helpful to help you think about MRD here. And sorry I can't be there in person. If any questions, feel free to email me. My email here is below, jimmy.lin@freenome.com, and hope you have a wonderful rest of your conference.